Hi, my Be Health Empowered family. Welcome, welcome, welcome back to another week of Excuse Me, Doctor. My name is Dr. Melissa Clarke. Of course, you know me as Dr. Mel, and I am delighted to be back here with you this week. We are doing what we do every week on Excuse Me, Doctor. We are making sure that you have the information that you need to make wise health decisions. And of course, we're streaming on YouTube, we're on Facebook, we're taking questions live. So that means three things. The first is if you're on Facebook, please hit like. I really appreciate you for that. And on YouTube, please hit that red subscribe button. Again, love it when you do that. And please remember, put your questions and comments in the chat because we are here for you so that you can get your questions answered. So thanks again for tuning in. And now let us get into creating an amazing week for ourselves with all the health questions that we're going to cover today and all the fantastic health topics. To do that, I have to have my co-producers. Let's first start off with Mr. Wayne Bruce.
Howdy, howdy, howdy. What's going
Hey,
on, Dr.
Wayne.
Mel? How are you?
I'm doing
Everything
great.
going well for you?
Everything is going
Okay, everything
fantastic. And
fantastic. Okay.
we have our other co-producer here with us this week, right?
Well, you keep reading into my lines, Dr. Mel. I think there's a problem here. I think we've gone over these lines a time or two. And so last week we started a new section, and I have to introduce the section each time, Dr. Mel.
Oh, right.
Right,
Okay, all
right,
right.
right.
Go
Don't
to it. Go to it.
just you take my stuff away, Dr. Mel. I don't know. I don't know how to feel about this. So look, uh, since we were a trio and we're not a trio as much anymore, since our former co-host and co-producer Lila had to go to Hollywood to finish doing her thing, we've added a new segment where we have guest hosts, and I'm excited to bring back for week number 2
Two.
our guest host. She hails from the fair state of Maryland, but she actually lives in the fair state. We can't say where you live. We don't want people to know where you live. Anyway, but she's incredible. Bring our guest host into the studio, Miss Bria.
Hey, Bria. We can't we can't hear you. There you go.
Oh,
Now we can hear
hello.
you.
I can't
Welcome,
co-host
welcome.
without no sound.
Fantastic. So now I have both of you all to bring us the word from the street, what's on everyone's mind. You all are the voice of our audience in the studio. So thank you both for being here.
It's what
Thanks for
we
having
do.
me back. Awesome.
So
Great.
everybody's checking in from everywhere. I just want to remind everybody once again to subscribe, to like, to follow, and check in. Put all your questions in the chats if you're watching live right now. And that's for our radio audience, right? If you're watching
Right.
live right now. If you can't watch live right now, Monday nights at 9 p.m. is when we tape, right, Dr. Mill?
That's when we do it. And so if you
Eastern.
want to join us, if you want to join us and make sure that your questions get answered, join us right here on Facebook and YouTube.
So let's get into it. The week that
Let's do
was
it.
in health and wellness.
Well, shouldn't we first talk about the show that we're going to do tonight? I mean, we got to let people know what they're going to be sticking around for, right?
Wow, we do.
Yeah.
Actually,
Probably important, right?
when the student becomes the teacher, this is what happens.
Because it's going to be a fantastic show. I
It
mean,
is. It is.
we
It's going to
know
be.
that we're going to be talking about staying on top of your health. And COVID interrupted, a lot of stuff, including people checking in with their doctor, doing their normal things that they do to stay healthy. So today is all about getting back on track with staying on top of your health. We have two incredible doctors, a men's health expert, a
Mhm.
women's health expert. They're going to tell us about what to focus on at every age, starting in every decade, basically, starting in the 20s, going all the way through the 70s and 80s. Screenings, vaccinations, lifestyle changes, menopause, andropause. A lot of people don't even know that that's a thing.
Yeah.
But we're
Don't
gonna
like
Learn
to
be
something
talk
new
about
today.
that. Men don't like to talk about that.
I
We're gonna
know,
talk
and
about
they
it
act like it.
today.
Right, we're gonna talk about it today,
The
and
Men
they
All
act like it's
Pause
not real.
was a song
Right.
in the
Well, there should
80s.
be another one called the andropause, right?
Okay. All right. All right. We
And we're
get it
not
on.
talking about Android phones either. I'm just saying.
Right. Okay. Fantastic. Fantastic. So now, now that we know what the show is about, we can get into what happened in the week of health and wellness. How about that?
Yep.
There
Let's
you
get
go.
into it.
Here we go. Let's get into it.
All right, we always got to start with the COVID update, and COVID's here to stay, it seems. So let's get a little bit into the hospitalization rates. What's that looking like, Dr. Mel?
Well, cases are still high. Hospitalizations, a good thing, are holding steady. They have not gone up. And I think, and the same with the number of deaths is still somewhere between 350 and 400 people a day. Way too many, right? But much, much, much,
Yeah.
much better than we were doing. I think it's a testament to the number of people who've had some protection against severe COVID, mainly due to prior disease or, most importantly, immunization. And also a
Mhm.
number of treatments that we now have 2 years of experience with. And I think we're just better at treating it as well.
I mean, that's good to hear. That's really, really good to hear. And that's attributed to vaccinations, right? Like these vaccinations are doing a little bit of something for acute disease of COVID, but also long COVID, right?
Right. And a study just came out that getting vaccination actually decreases some of those effects of long COVID, like blood clots and heart attacks and strokes. Full vaccination against COVID-19 was associated with a reduced risk of heart attack and stroke, as far as sort of that 3-month window after you've had COVID. And so that's good, additional good news, an additional reasons for getting vaccinated.
Okay, I guess we got to keep proving to people that these vaccinations work, right?
I'm telling you.
Because people don't believe
Right.
it.
Right.
Right.
And so then talking about long COVID, even though it sounds bad, there's some good news that's coming out about long COVID, right?
Yeah, actually, the good news is that it turns out most people who lost their sense of smell or taste as one of their long COVID symptoms, turns out that after about 2 years, 88% of people have it back totally. About 10% of people have it back partially, and only 2% of people say, their symptoms got worse. So that's actually, I think, pretty good news because we hadn't really heard anything about how these long COVID symptoms sort of resolve, what the time frame is. So that's great to hear. And also, to other good news is the Biden administration has announced that they're putting sort of the full resources, a concerted plan at the federal level into fighting long COVID. I'm honored to have been interviewed by the White House in their development of that plan. So I'm glad to see that 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 actually they have now announced it and they're moving forward with it.
Oh, that's y'all talking to a superstar right now.
Dr. Mel
I
is
know y'all.
in the White House plans. What's going
Well,
on?
Right.
I mean, they realize that, because of all the work that I've done with the Black Coalition Against COVID, and also hearing from the audience, the audience, putting everything in the chat has allowed me to be able to, you know, understand what some people's concerns are regarding long COVID. So that you all are a great part of that.
Wow. That's fantastic, Dr. Mel. Well, look,
Congrats.
we talk about COVID so much. We've talked about COVID so much. And everybody mentions their COVID 20 that they gained in the past 2 years.
Yeah.
Some COVID 25, some COVID 10. But
So
now the
somewhere
people
in there.
now the people getting their taste back, they might even gain more. But some interesting facts came out about we're actually losing a half a pound, but it just happens to be a muscle every year.
Yeah, so we peak at 30 in terms of our muscle mass. And then if we don't do anything about it, we lose about a half a pound of muscle a year. And of course, that contributes to weight gain, but it also contributes to um, greater weakness as we get older, more likelihood of aches and pains and less mobility, all of which can lead to an increased risk for fall and injury. Um, but it turns out that we can do something about that to slow it down. Specifically, two things. One is starting to bring in resistance training. So don't just do aerobic exercise, do resistance training about 3 days a week and getting enough protein in our diet. That really doesn't get emphasized enough. And I think it's important to know we should be getting about 1.5 to 2 um, grams per kilogram of our body weight of protein per day. And that, especially as we age, helps to make sure that we don't lose that muscle mass, um, you know, as nature would have us do if we didn't do anything. So,
Mhm.
really important to keep in mind.
All right.
That's
Changing to
good to
those
know.
protein meals.
Yeah, I got 5 more years until I start losing some muscle. So let me get it together now.
Get
Did
it
she say
together.
she had 5 more years?
She did. Yeah, she did. She gave her
God,
age away. But
God
I mean,
Oh,
bless her. God bless
yeah.
her.
well,
See, in
welcome.
in 15 years when you're trying to hide how old you are, somebody's gonna dig up this video and be like, "Oh no, she's 40."
Y'all never heard this. Y'all never saw this. We wasn't here. Um, so let's talk a little bit about stress incontinence. And for those who aren't aware what incontinence is, it occurs when you do maybe like coughing, laughing, heavy lifting, and you urinate on yourself a little bit. And so, and Dr. Mel, you can add on to that if it feels like it's not comprehensive. But I know there's some studies coming out about acupuncture helping stress incontinence. Can you talk a little bit about that?
Yeah, so it turns out that something called electroacupuncture, they did a study, they reviewed, all the studies that are out there about acupuncture and stress incontinence, which by the way, you hit exactly what stress incontinence what is.
Perfect.
And electroacupuncture is a traditional Chinese medicine practice of using very, very fine needles in certain areas of the body and then activating them further by putting a little electrode on it. It sounds a little off, not something that we're used to, but acupuncture has actually been shown by the World Health Organization to help a lot of things, especially chronic pain. And it turns out now that it does seem that it has some positive effect on improving stress incontinence, even over the
Mm.
other traditional treatments for stress incontinence. So if you have stress incontinence, it might be something good to talk to your doctor about, thinking about a course of acupuncture.
Okay, well, look, we have such an incredible audience in the chat, and one of my favorites, she knows she's a favorite, is Valerie Spalding Parker, and she says stress incontinence is when you depend on depends.
Yes,
Kinda,
true. That is a good way to put it.
yeah. She's a budding
Nailed it. She nailed it.
comedian. She has it, but 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 where are they putting the needles, Dr. Mel? I mean, from a man's standpoint, that's
Oh
where I
God.
would be concerned.
Yeah, yeah, no, it's nowhere near the genital area, if that's
Okay.
the concern. It's along certain meridians, which is in Chinese medicine, the idea is that the disease comes from blockage of energy, and energy
Mm,
travels along certain lines in our body, and so they put the needles along those lines. Most typically for these kinds of treatments, it would be in your back or your arms or your legs. So no, nowhere near the genital area. You're good.
And Dr. Mel, you were certified in Chinese medicine, right?
Yes,
Or acupuncture.
I studied acupuncture and was certified in acupuncture.
Wow.
Absolutely.
I'm impressed. I'm impressed. I'm impressed. But I'm telling you what I'm not impressed at. As I age, and men get this more than women. We're not talking about incontinence. We're gonna talk about something else that men get. And that's if you eat too much red meat, or some people eat shellfish, they get, as my parents would say, the gout. Right?
Gout.
The gout.
Yeah. And as a
Why did
matter of
everything
fact,
start with the? But they started with the
right,
gout,
like the sugar, right? The
the
gout.
sugar, the gout.
Yeah. So, yeah, they call gout actually rich man's disease because it comes
Mhm.
from eating a diet of red meat and shellfish, things that traditionally people who have more resources can afford. And it hurts. It hurts terribly. It's caused by a buildup of acid, uric acid specifically, in your system that gets stuck in your joints, most commonly the big toe, but it can be other joints in the body as well. Um, so it turns out, as if all that's not bad enough, after you have a flare of the gout, for the next 2 months after that, you have an increased risk of heart attack and stroke.
Oh wow.
So people who get these flare ups should know that because it's basically your body telling you slow your roll, see your doctor, and focus on these things. An anti-gout diet, and your doctor can go over that with you, which will help to lower your cholesterol. But if it doesn't, there are also cholesterol lowering medicines that you could take. If you smoke, quit smoking. And then, of course, if you also have diabetes and or high blood pressure, make sure that those are under control. Doing that in partnership with your doctor will help to lower that risk of any of these heart problems or stroke problems coming after a flare of gout.
Wow, that's
That's
serious.
crazy.
That's very
Yeah.
I guess
serious.
I
But
guess
the
that
good thing
goes like
is you
right.
can, take all these things as warning signs from your body about, hey, if you what is it, the Einstein quote? If you continue to do the same thing expecting a change, that's insanity, right?
Right.
So
Mhm.
it's an opportunity. Your body is telling you,
To
hey, you can't
change.
keep doing what you were doing and expect a different result, right?
All right.
Okay.
So
So we've come to the end of the recap. You know what time it is, right?
what
What time is it?
It's time for
The weekly debunk, stopping misinformation in its tracks.
Okay. Okay. So last week it was Tracy Twitter fingers, right? But now this week it's Tommy, her nephew. They all just coming out the woodworks at this point in time. And I do want to preface this message by saying Tommy has a couple of phobias. Just a disclaimer to our audience, of course. So he brought up monkeypox and said that monkeypox ain't nothing but a gay disease. And since I'm not gay, I ain't worried about it. And so I said, I don't know about that one. Excuse me, Dr. Mel. Is that true? Because it can't be, right?
yeah, anybody can get monkeypox. It is true that right now it's mainly the cases that we're seeing are mainly in the community of men who have sex with men, but it is not an exclusively sexually transmitted disease. So therefore, there's a strong possibility that at some point it will spread beyond that population of individuals. That's partially why it was declared a public health emergency this past week by the Biden administration. And we know that there are currently about 2 women and 5 children who have contracted monkeypox to date in this country. So let's go over a little bit for Tommy's benefit how monkeypox spreads. It spreads through prolonged, close, skin to skin contact, which doesn't necessarily have to be sexual, right? It can happen
right.
outside of sex. So, direct contact with the monkeypox rash or bodily fluids from a person with monkeypox is one way that it's spread. Or if you, again, have prolonged contact with objects or fabrics like clothing or bedding or surfaces that somebody with monkeypox who has active sores um, has encountered, right? And then
Mhm.
finally, contact with respiratory secretions. Unlike COVID, though, again, it has to be prolonged face to face contact. It's not just like a
Mm.
casual conversation you have with somebody, which is more like how COVID spreads. So, the other thing about monkeypox that people need to know is that you are infectious as long as the rash is there. So, the rash has to scab over and new skin form before you are no longer contagious. That takes
Mm.
2 to 4 weeks, and you need to be isolated. So, during that
Oh,
time,
wow.
yeah, so it's not something you want, even though, it's way less fatal than COVID.
Yes.
It's unusual to die from monkeypox, but you have to stay isolated for that 2 to 4 week period of time. There are vaccines, there are treatments, they're in the process of being rolled out. Um, but no, this is not exclusively a sexually transmitted disease, nor is it exclusively a gay disease.
Thank you
Fantastic.
for clearing that up because I think a
Thank
lot
you.
of people have that misconception. But 2 to 4 weeks, man, people are
Yeah.
indoors for 10 days and going
And
crazy.
they're climbing the walls.
Right. Right.
Exactly.
People were inside for 10 days and losing their mind.
Yeah,
Don't
So
be
exactly.
careful, y'all. Be
be
careful.
careful. All right, Dr. Mill, that's it
All
for
right,
us.
we're gonna see y'all back in a little bit. Thanks so much. And
All
we are
right.
gonna move into our show topic for tonight. And I gotta remember to tell you, make sure you put your questions in the chat because we are going to be getting to them. So, have you gotten back to your regular checkups? Did you ever have a schedule for regular checkups? Well, if not, this is the show that we're going to be talking about what you should be doing at each age, working with your doctor to stay healthy, active, and disease free, right? And of course, it doesn't just vary with age, it also varies from men to women by gender. So I have two incredible experts who are going to help us understand how to partner with your doctor to stay healthy at every age. So, to talk about women's health, we have Dr. Suleika Michel. She is a board certified OBGYN with over 22 years of experience. She's also a speaker, a best-selling author, and an advocate for mental health for maternal health, to reduce health disparities, mortality, and morbidity, um, especially in the Black community. So welcome, Dr. Michelle. Thanks for joining us.
Glad to be here.
Absolutely. So Dr. Michelle is going to talk about women's health, and to talk about men's health, we have Dr. Sidney Nelson. He's a board certified internist or internal medicine physician. He's been featured in several popular publications. He prides himself in taking a holistic approach to each person, mind, body, and spirit, and he calls himself the around the way doc, reflecting his commitment to stay accessible to everybody, especially those in the Black and Brown community. So, welcome, Dr. Nelson.
Thank you very much for the invitation.
Absolutely. So, I want to make sure that the audience first understands where you all are coming from. What is your philosophy for how you approach health and how you partner with your patients and even the community? So, let's start with you, Dr. Michelle. Tell us, how do you help your patients in the community stay healthy?
I think the best way we can help patients stay healthy is with preventative care. So our goal is to do a lot of education, particularly regarding screening tests, sexually transmitted infections, other female health concerns, so that patients can take control and truly be a partner in their health care.
Fantastic. Fantastic. And then what about you, Dr. Nelson?
Yeah, so I think that, piggybacking off what you said, that preventive medicine is big, right? We want to make sure we stop the process of the disease spreading. We want to nip it in the bud. I try to do boots on the ground. I'm a community person, community physician. I like being active in the community. I partnered up with several community organizations, one of them being Life to Your Health, which goes to the barbershops. We got a thing for African American males, which is a good place for us to kind of be there to educate men and tell them about what they need to do and do screenings at the barbershop. Also, I've been part of the CDC in Baltimore City, where we put on health fairs and make sure when people come into the community center, we do screenings and do education and let them know that, hey, these are things that you're at risk for, and these are things that we can actually fix if we get them early enough. So a boots on the ground approach for me has always been good.
I love that, boots on the ground. So, well, let's go through this. I want to start off and sort of talk about each decade of life and what you should be looking for. Let's start with men because we normally start with women. So let's start with men in their 20s. I mean, they're healthy, they're, for the most part. What should they be thinking about in terms of men's health in your 20s?
So yeah, like you said, I think in the 20s we all felt that we were indestructible. So for the most part, our consumption of Big Macs and cheeseburgers were probably higher than they should have been. But we do have to be cognizant of the fact that we do turn into the 30s and 40s and so forth. So being conscious of your diet is really big. For my patients, my patients in their 20s that are men, I already stress the fact that we want to be worried about the disease process of diabetes and high cholesterol. So I always want to screen for that. I want to make sure I'm checking what's called a fasting lipid panel for cholesterol and checking hemoglobin A1C for screening for diabetes. We also want to make sure we're checking for obesity. We want to make sure that our weight's in a good place. As we all know, as we get older, it's a little harder. So we want to start when we're young to watch our weight and make sure that we're in a good range. I'm of the fan of not necessarily doing a BMI. I'm a waist size kind of guy. So I tell my men, you want to be in a belt size between such and such, usually between like 34 and 36. And also, we want to make sure that there's things like our blood pressure we want to look at, right? So in your 20s, you can still have hypertension, you can still have high blood pressure. And so you want to make sure the blood pressure is being checked. You want to make sure that your doctor is doing that. And those are some of the things in the 20s, I think, that as far as screening, you really need to look at for men.
Right. And especially in the Black and brown community, like you said, that trio of obesity, diabetes, and high blood pressure are there for both men and women. Are there any cancers that young men need to be checking themselves for?
Yeah, so incidentally, there's a big cancer for young men that we're worried about is testicular cancer, right? But lately, what they've seen is that the self exam is probably the best thing for screening for testicular cancer. Testicular cancer screening, for the most part, is not done by the clinicians as much anymore. As scientists, we do studies and we look at incidence and prevalence and things of that nature. So, for young men, really the big thing is just making sure you stay on top of doing your testicular exam, looking for any kind of abnormalities.
Great, great. So women in their 20s, let's say 20s and 30s, what should be the focus, Dr. Michelle?
I think for those women, particularly those females who are over 21, the first thing is the pap smear. The pap smear is a screening test for cervical cancer and precancerous changes. And it's done initially at age 21. We used to do it much younger, but we found that the test had more false positives. And we also know that the incidence of cervical cancer in patients who are younger than 21 is extremely low. It's about 1%. We know that about 78% of our cervical cancer cases are diagnosed in women who are aged 30 to 39, and 21% are diagnosed for women in ages between 20 and 29. The other thing that we urge that patients to get tested for if they are sexually active is sexually transmitted infections. The pap smear can screen for the HPV virus, the human papilloma virus, but the pap smear alone is not specifically targeted for other infections. So if you feel like you're at risk, definitely share that information with your providers so that the provider can go ahead and offer the testing. We can do testing vaginally, we can do testing through urine, and some testing requires blood work. So I would definitely encourage that. We're also encouraging vaccination against the human papillomavirus, which is with the Gardasil vaccine. And that's usually started with our pediatricians, but for patients who haven't gotten it by the age of 21, where they see myself as an OBGYN provider, we're definitely encouraging that. And we're encouraging mammograms in the 20s and 30s only if there is a significant family history of breast cancer.
Mm-hmm.
So, for example, if there's been breast cancer in a first degree relative at the age of 40 or 45, then we're encouraging the initial mammogram to be done about 10 to 15 years prior to that age, as opposed to starting at age 40.
Wow, that's excellent to know. So those risk factors really make a difference, knowing your family history, if at all possible, so that you can communicate that with your doctor so that you could choose the appropriate age to start the mammogram screening. That's really great to know. Um, so now let's talk about 30s and 40s for men. Um, what should men be starting to think about? We already talked about, I don't know if you heard the recap that you start to lose about a half a pound of muscle a year or 5% of your muscle per decade. So what should men be thinking about as they're moving into their 30s and 40s?
So now the 30s and 40s get interesting, right? That's where it all begins. Um, it gets real fun. So going through your 30s, for the most part, you're still doing the same screening that you're doing in your 20s. But when you creep into that 40 mark, that's when the fun begins. Now we have some more severe and serious conditions and disease processes that can occur. And so let's remember, screening. The big thing about screening is, one, we want to reduce incidence, right? Number two, we also want to make sure that we decrease the likelihood of severe disease if we catch it early enough. And number three, we want to reduce the mortality or the possibility of death from the disease. So in this category, we have some disease processes that we really have to worry about. As you've seen recently, they changed the screening for colon cancer from 50 to 45. And so they did that recently because they saw there's an increased incidence of colon cancer in younger people. And so we saw that with several stars. And so it's one of those things where I'm very, very, very interested in making sure that my young men, my 45-year-olds, are starting our colon cancer screening. I tell them, listen, it's done by a gastroenterologist, that's a GI doctor, a stomach doctor. The test is, you're not going to be up for it. They're going to put you to sleep. You don't have to worry about that. It's very simple. 5, 4, 3, 2, 1, you sleep, you wake up, and it's done, and you've been screened. So colon cancer starts at 45. Now, the other thing we have to worry about is prostate cancer in 40s.
And actually, before you jump into prostate cancer, that 45 year old mark is for men and women, right? It's not just for
Yes,
men.
that's correct. That's
Okay,
correct.
Absolutely.
I just wanted to bring that out. I know I myself started in my 40s because I had a family history um, uh,
Mhm.
of colon cancer, so I started early. So
Yeah, and definitely, what we tend to do is, subtract 10 years from the age of the family member when they had it, if it was at a young age. So yeah,
mhm,
that definitely happens. But 45 is for both men.
yep. All right, and then you were about to mention prostate cancer.
Yes, prostate cancer. So prostate cancer is another one. And we have to, prostate cancer is one of those things we have to look at seriously, because in the African American male, there's a twofold increase in mortality from prostate cancer. And so I'm really big on making sure that we're getting screened for that. Now, there's two types of screening. There's the PSA, which is a blood test, and then there's the digital rectal exam. Studies have shown lately that, honestly, the digital rectal exam in a primary care setting is really not of use. We do use the PSA
I
still,
think
though.
men will be happy to hear that.
Yeah, I'm sure there's a lot of applause going on out there, cheering and all that good stuff. Um,
Right.
but yeah, it's just one of those things where you're not necessarily going to always catch things if you do a digital rectal exam, because you're looking for the architecture of the prostate, and sometimes it's internal, you might not catch that. So we do the PSA. Typically, I start with the PSA screening at like 40 to 45, 45 to 50, all depending on the history of the patient. If they have primary family members, meaning like a father that had prostate cancer, I may start earlier. And it's a discussion, right? All this is a discussion. You got to sit down and talk to the patient, make sure you understand what's going on. If I have a 41-year-old, I say, hey, this is what's going on. You have a father that had prostate cancer. You may want to start now. And they may say, yeah, I want to do that. Or, you know what, give me some time. I'm very stressed out about this. And, just the thought of having that disease worries me right now. So it's a conversation always when we have these screening tests to make sure that, you and the patient are, squared up and looking at things at the same way.
Right. And so let's move to women. We talked a little bit about women in their 40s, 30s and 40s, but around the late 40s is when menopause comes knocking, right? So, what are some of the things that we should be thinking about, Dr. Michelle, for women?
So menopause can definitely start in the 40s. And that is really, really the key to know for patients who are considering childbearing, right? So if they're 40 years old and really hoping to have a child of your own, that may be concerning. So just backtracking to the age 20s and 30s, if you're someone that's considering delaying childbearing, getting a test to just get an idea of your number of eggs and how viable those are would also be a screening test you would get in your 20s and 30s. And just to piggyback on what Dr. Nelson was mentioning regarding colon cancer screening, there are blood tests that we can do and saliva tests that we can do for genetic screening for patients who have family history of colon cancer, breast cancers, any other types of cancer, so that we can see if the patients have an increased risk for those cancers. So if you do have a significant family history of those cancers, I would definitely recommend sharing that information with your OBGYN provider so that they can do genetic screening. And so moving forward to the 40s, as patients are leaving the childbearing ages, there are a number of symptoms that can occur. And unfortunately, that transition into menopause can last for years. Menopause is when a woman has not had a cycle, a period for at least 12 consecutive months without any type of hormones. But the symptoms transitioning into that, and even afterwards, can range from hot flashes during the day, night sweats, mood swings, vaginal dryness, decreased libido. And a lot of those symptoms can be treated, and they don't necessarily have to be treated with traditional medication. So if you're someone that is either not a candidate for traditional hormones or truly not interested in traditional hormones, share that with your provider, because we definitely have other options for treatment. You do not have to suffer with those symptoms.
Right. And the other thing I think about going through menopause for women is as your estrogens fall, you lose the protection that you had against heart disease. And so that's probably another thing to start to think about in terms of some of the things that Dr. Nelson was mentioning for men in their 20s is really true for everybody, focusing on, cholesterol, diabetes, high blood pressure, making sure that you're not at risk or on your way to develop any of those. So we're now in our 50s. Are there things that we should be thinking about? Let's just say 50s and 60s in the interest of time.
Sure.
Are there things, especially vaccinations or other screenings, that we should be thinking about? Dr. Nelson, let's start with you.
Yeah, so in the 50s, the 50s are definitely not as they're a little bit more boring compared to the 40s, but there's still a lot going on there. You have lung cancer screening that pops up in the 50s for those that are smokers, and that's for both men and women. If you've had a 20 years history of smoking, and then we say hey, a 20 pack, sorry, per year history of smoking, we suggest that you have screening for that, which entails a CT or a CAT scan of your lungs. Now, there is a benefit if you stop smoking. If you stop smoking and it's 15 years prior to that, then you don't have to do that screening. But if you're still smoking and you hit that mark, then we do screen for lung cancer.
Great. What about vaccines? When do we start thinking about shingles and pneumonia? Those two in particular,
Yeah,
and
so
COVID.
for shingles, 50 to 55 is typically the time period that we're doing a shingles vaccine. I highly suggest to my patients that they take it. My lovely mother-in-law, she has shingles, and it was very hard to see her go through that. So I tell people, from a personal standpoint, you really want to make sure that you get that vaccination done. It's very simple. It's very effective. It's 2 shots spaced out, and so I highly recommend that. And then when you creep into your 60s, then you get your pneumonia vaccine. So at 65, and we know that as you get older, I always like to say, as you progress through life, you have to worry about those kind of processes that you're more susceptible to than when you were younger. And so pneumonia is one of those. So we have pneumonia
Right.
vaccine for that.
Right. And also getting that second booster for your COVID
Yes.
vaccination too. You're eligible after you're over 50. Andropause. We talked about menopause. Is andropause real, Dr. Nelson? And what do you tell your men who come in concerned about sort of changes that they're seeing?
So I think there's a certain level of reality to it, right? I'm always about acknowledging the patient how they feel. So what andropause is, it's just a decrease in testosterone that occurs, and that's a natural phenomenon. It's not as abrupt as in women, right? Women have kind of an abrupt change in their hormones. Men, what we found is once they get to 40, there's kind of a 1% decrease in their testosterone level over the years. So it's not as abrupt, it's a gradual decline. But yet still, we do have some men that are affected by that decline. We have symptoms like decreased libido, depression, decreased muscle mass, breast formation, things of that nature, which, for anybody could be of concern. And so the thing there, though, is I always say, once you open Pandora's box, what do you do about it, right? And so that's where the problem is with andropause. How do we treat it? What do we do? There is testosterone replacement therapy, but there's risk to that, right? Depending on what age you are, when we're talking about this, if you're still, in the process of wanting to have kids, you can't take testosterone therapy. If you're at risk for prostate cancer, you can't take testosterone therapy. If you've had a heart attack, if you have a stroke, so it gets really complicated as far as treatment for it. But we do see that clinically, with that decrease in testosterone, andropause does, have a prevalence, or there is a presence of it in his life.
So it is real. Okay. That I think that's education for some people in our audience. And then just to wrap up, before we get to our audience questions, 70s and 80s, are there any screenings that we can stop as we get older, approaching our 80s, for example?
Yeah, I'm of the vein. Listen, man, you make it to your 70s and 80s, man. Live your life, have fun. That. But with that being said, there's some patients that are still really into their health, and so I have that discussion with them. I say, listen, your risk is lower now. The chances of you getting advanced disease are lower. The chances of you having the issues that you would have if you're younger are lower. So we can stop. But I have patients, that are, 70 still want to have colon cancer screening. They still want to have prostate cancer screening, with the PSA. So it's really a discussion, at that point in time. But, I always tell them, live your life.
What about pap smears and mammograms, Dr. Michel?
Yeah, so mammograms we're starting pretty much yearly at age 40, and the pap smears we're continuing, generally speaking, every 3 years for low risk patients, more frequently if they have abnormal pap smears. But we're stopping pap smears, generally speaking, around the age of 65. If they've had normal pap smears in the past, if the pap smears have not been normal, then the testing is continued. The one thing that we are going to continue is potential screening for sexually transmitted infections, because we've noted that sexually transmitted infections have increased in our population over the age of 65. It's more than doubled in the past several years. And that is because at that time, patients no longer have to worry about pregnancy. So they're not using condoms because they're no longer concerned about pregnancy. So it is not uncommon for our older patients who are widowed or divorced and re-entering the dating scene having an infection. So just having that relationship with your provider and sharing that information lets us know whether or not we need to continue that screening.
Wow. Well, we've covered a lot. I think one common theme is continue to use condoms no matter what age you are. Continue those screenings, partner with your doctor, and let's bring back Bria and Wayne to bring in some questions from the audience.
Yeah.
I know we've covered a lot. We've gone from 20 to 80 in 20 minutes. So.
Right.
Yeah.
I'm trying to write down and remember stuff. Fantastic. Bria, questions. What do you got?
All right, let's get into the first question. This question is from Yvonne Smith. They ask, what is supposed to happen at your annual physical? After the test, should they explain the results other than saying everything is okay?
Dr. Nelson, you want to take that?
Yeah, definitely. So, once you have your annual physical, you definitely should have a review of your labs to make sure everything's okay and to let you know how close you are to not being okay. You got to think for like if I do a screening test like a hemoglobin A1C where there's a risk for prediabetes, I also like inform my patients, listen, your number wasn't pre-diabetic, but hey, you were 0.1 off. So we still need to make some changes so that in the future we don't have an issue with that. But it's definitely good to make sure you go over your test with your physician just to know what's going on.
And ask questions if they don't.
Mhm. Yep.
Say,
Absolutely.
what do these labs mean? Right?
Yeah, because a
Mhm.
lot of times the patients are getting the results before the provider in their portals. So if you have a question, feel free to reach out to your provider to get clarity on the findings on your labs.
Mhm.
Fantastic.
Absolutely.
We have another question, and it comes from Tracy Walls. Why is there a disconnect concerning women who have had a hysterectomy and getting pap smears? If you have had partial, should you still get a pap smear?
Dr. Michel, that one is clearly for you.
Oh, that's a good question. So, layman terms for partial hysterectomy just needs to be clarified from a medical standpoint. When we say partial hysterectomy, we mean that your cervix is still remaining. My gut is telling me that when you're saying partial hysterectomy, you're meaning your ovaries are remaining. Hysterectomy means removal of your uterus and your cervix. It has nothing to do with your ovaries. So for the most part, most people have had a complete hysterectomy, meaning they have had their entire uterus and their entire cervix removed. If that is the case, the pap smear doesn't apply, right? Because the pap smear screens for cervical cancer. If you don't have a cervix, then the pap doesn't do anything. The only time that we're doing a pap smear is if you've had a hysterectomy for an indication of an abnormal finding on the cervix. So we're trying to screen for potential residual disease on the vagina. But if you have had your uterus and your cervix removed, you no longer need to have a pap smear. If you have your cervix intact, you still get your pap smears under the usual protocols.
And if you don't know, go to your OBGYN. They can examine you and let you know.
Absolutely.
Right. All right. What else do we have?
Alrighty, so let's get into the next question. This one is also from Yvonne Smith. Bone density tests. When and how often?
So we start bone density tests, generally speaking, at age 50. There are some patients who have been on injectable forms of contraception, such as Depo-Provera, which can cause a temporary reversible bone loss. For some of those patients, we might do screening a little bit sooner to see if they can stay on that medication. But generally speaking, bone density test screening begins at the age of 50, and depending on the findings, they're done every 2 to 3 years.
And last week, our show was about, is race real? Meaning, do Black people get diseases different than white people and vice versa? So is it true that Black people don't get osteoporosis or weakening of the bones, Dr. Michel?
That is not true.
Okay.
That is not true. So
Just
Black
to be clear.
patients still get osteoporosis and osteopenia, which is bone loss that doesn't quite meet the criteria for full treatment with osteoporosis. So the screening timing is the same for our Black and brown population.
Great to know.
All righty. We have a question from Michelle Cook. She says, my husband would like to know how often to check prostate for men in their late 30s. Also, what does full blood work consist of?
Oh, that's
All
a
right.
good one.
Dr. Nelson?
Yes. So interesting enough, in the 30s, for most men, we don't do prostate screening. If, however, you have a family member, say your father had prostate cancer in their 30s, then we, of course, we would kind of shift the screening time. But typically, for the most part, we start between 40 and 45. But like I said, that's only if you don't have like a primary family member, like a father, that didn't have prostate cancer at an early age.
And I think the second question, thanks for that, Dr. Nelson. The second question was, what is quote unquote full blood work that you should
Right.
be getting at a physical?
So it's funny, I have a lot of patients that ask that, and so we kind of just went over it, right? Full blood work is different for everybody, depending on what age. But I think at a minimum, full blood work should include, checking for your fasting lipid panel to make sure you don't have high cholesterol, checking the hemoglobin A1C to make sure that you don't have any evidence of prediabetes or diabetes, making sure that you're not anemic. That's what's called a CBC. Then also checking what's called a CMP, which is a complete metabolic panel. That's making sure that your kidneys look good. That's making sure your electrolytes are good. That's making sure that your liver function is good. And then also checking your TSH, which is for your thyroid. I think, at a minimum, those are good tests to have in a full workup.
Is there anything you would add to that, Dr. Michelle, or is that the same pretty much for women as well?
It's pretty much the same. Again, for my patients in their 20s and 30s, I'm more concerned about their ovarian future childbearing because women are delaying childbearing these days. So I'm encouraging at least understanding what their values are with their ovarian reserve. I will say this, we have a lot of patients that come in asking for the complete blood screening that Dr. Nelson was referring to. We tend not to draw that because we draw tests on things that we are going to address. So we are not necessarily screening for diabetes and all those kinds of things unless it is affecting them from a menstrual cycle perspective. So menstrual irregularities, we're concerned about, we'll test that. But generally speaking, for full blood work, you really need to have a primary care provider in addition to a specialist like an OBGYN.
Great point. And I think that's a lot of women in their childbearing years only go to their OBGYN. So I think that's a really important point, that if you have other health conditions, especially obesity, high blood pressure, diabetes, asthma, which are things that are common in women in their childbearing years, you should also make sure that you have a good PCP, primary care physician, as well.
Most definitely.
Yep.
All
Bria.
right. I think we have time for one more.
Bria, you have a question?
Alrighty. Yes, I do. This is from Kim Williams. Is stopping pap smears at 55 a doctor/patient decision, or is it an insurance decision?
Good question.
That's a great
Mhm.
question. And we stop them at 65, not 55. So 65, not 55. And it's more a decision based on data and the incidence of cervical cancer after the age of 65. So do patients have pap smears after that? Absolutely. Is it always covered by Medicare? Not necessarily, but some patients are willing to pay out of pocket to continue their pap smears, and that's okay, especially if they're in the dating scene and they're concerning about contracting something. It's definitely encouraged. And sometimes we can actually speak with the insurance company to make sure it is covered. But just because that's the recommendation does not mean that that's the end all be all. I mean, we recommend mammograms up until age 75. Do my 80-year-olds sometimes have mammograms? Absolutely, because they're living their life and they're swearing they're going to live till they're 110, and they want to make sure they know what's going on. So you can still have that conversation, and if necessary, many times we can get that covered. The frequency of it may not be at the whim of the patient. It may still be every 3 years, but they still have the option to have a pap smear.
Great. And I love that, because I think that's a great place to end, really emphasizing that customization and that
Mhm.
personalization, which I think has been one of the themes. There's certainly recommendations about what we should be doing at every age, but our family history, our lifestyle, all these things really affect it. So I really want to thank Dr. Michelle and Dr. Nelson for just breaking it down in a really easy to understand way. You guys were fantastic. Thanks
Incredible.
so much for being here
Thank
with us.
you.
Thanks for having us.
And
It's been awesome.
absolutely. And thank you, Bria. Fantastic as always. And
Thank
to my
you.
wonderful co-producer and co-host, Mr. Wayne Bruce.
Welcome.
Really appreciate you. And I want to just remind everybody, of course, that that study that I talked about, the Howard University COVID resiliency study, is still an option for you to participate. And if you've already done it, tell a friend, because all you have to do is fill out 2 surveys and you can be compensated up to $100 describing your experience in terms of how you've been coping during this pandemic. So if you have any interest, please reach out to Dana Harvey, and I'm going to give you her email. It's Dana, Dana Harvey, Harvey, research at gmail.com. That's Dana Harvey research at gmail.com. We still have some Howard University, which is doing the study, still has some openings available for those who might want to participate. Well, thank you once again, my audience. Y'all came through with some fantastic questions to make this a really informative show. And love you all for tuning in. Can't wait to see you all again next time. And remember, until I see you again, be wise, be well, and be health empowered.
So I guess I should thank the Robinsons. They invited me. They still don't know. I hooked up with Dave 3 days ago. He'll start coughing tomorrow. And I bet in 10 days he'll be on a ventilator. Now, his wife, she's not vaccinated because she thinks it'll prevent her from being pregnant. But what they don't know is that I can decrease sperm count. Sorry, Dave. Good luck.